Nutrition science evolves through milestones, moments when evidence deepens and practice transforms. Welcome to Milestones in Pediatric Nutrition, a podcast by the Nestlé Nutrition Institute, hosted by Professor Andrew Prentice. In each episode, leading experts reflect on breakthroughs that shape modern nutritional care, from early life feeding to practice-changing interventions across the life course. Because progress happens, one milestone at a time. This festive season, join us as we celebrate the discoveries that continue to improve children's health worldwide. Welcome to Milestones from the Nestlé Nutrition Institute, your daily dose of breakthroughs in pediatric nutrition this holiday season. Today, Professor Andrew Prentice is joined by Professor Stanley Zlotkin to discuss micronutrient powders, scaling simple solutions for micronutrient deficiencies, a milestone shaping the future of child health.
Welcome to our new podcast series, Milestones in Pediatric Nutrition, part of a wider series of NNI Bites Big Learnings. My name is Andrew Prentice. I'm Professor of International Nutrition at the London School of Hygiene and Tropical Medicine, and I live and work in the Gambia in West Africa. Now, in this new series, I talk to some of the world's leading scientists and policy advocates about discoveries and interventions that have made a huge impact in improving pediatric nutrition. Today, my guest is Professor Stanley Zlotkin, the inventor of sprinkles, and our milestone in pediatric nutrition is the more general topic of multiple micronutrient powders. As defined by WHO, multiple micronutrient powders, or often called MNPs, are single-dose packets of vitamins and minerals in powder form that can be sprinkled onto any ready-to-eat semi-solid food consumed at home, school, or at any other point of use. The powders are used to increase the micronutrient content of a child's diet without changing their usual dietary habits. As you will shortly hear, my guest played a pivotal role in their development. Welcome, Stan.
Thank you very much, Andrew. Great to be here.
Stanley Zlotkin is an emeritus professor of pediatrics, public health sciences, and nutrition sciences at the Monk School of Global Affairs and Public Policy at the University of Toronto, and a senior scientist emeritus at the Hospital for Sick Children Research Institute, often shortened to SickKids. His current research and advocacy is focused on controlling malnutrition in children globally. In recognition of his really pioneering work towards improving the lives of these children, he was awarded the CIHR National Knowledge Translation Award in 2006, the Order of Canada in 2007, and the Order of Ontario in 2015. He's the inaugural Chief of Global Child Health at SickKids. So you can tell that we've got a very eminent speaker in front of us. Before we dive into the details of sprinkles and the many Me Too products that your invention has spawned, let's hear about how you first entered the field of nutrition and what gave you your current zeal for helping to improve the lives of underprivileged populations around the world.
Thank you again, Andrew, for having me on your podcast. As a medical student at McMaster University in Hamilton, Ontario, in the third year of our 3-year program, we had a 3-month elective. And for each of the elective, we had to have a question or a hypothesis to test. The question I posed was, in a situation where you have a lot of people in very limited healthcare facilities, how are priorities determined? And I thought the best place for me to do this would be in an isolated hospital somewhere in Africa. And I ended up in Nigeria, at the northeast state of Nigeria, near the border of Chad, at the most remote Methodist mission hospital in the world. I spent 3 months there, no electricity, no running water. And
when was this done?
It was in 1973, long time ago. But it was not to be dramatic, Andrew, but it was a life-changing experience. I was this young kid from Toronto. I'd never been outside of Canada. My first real trip outside was by myself to a part of the world, again, that I'd never been to before. And at this hospital, I had an eye-opening, incredible experience seeing the role of public health. People generally were not immunized. They had no sense on hygiene. And that would come to the hospital with diseases that, of course, I'd never seen then and had never seen since. But I got a real strong sense of the importance of public health and particularly nutrition. Andrew, as you know, in this part of Nigeria, at least, there was a dry season, a wet season, and what they called a hungry season between the times when the crops were available for harvesting and eating. And again, it made a huge impact on me as a young person seeing malnutrition for the first time. When I finished my medical career, decided that pediatrics was the way to go and studied pediatrics, came back and did a PhD in nutritional sciences with the idea that ultimately I might be able to do something to alleviate the major challenges that I identified as a young medical student in northeast state of Nigeria. So that's kind of how it began, Andrew.
That's incredible. And you certainly have made a contribution, as we shall shortly be covering. I mean, one of the privileges of doing these podcasts is to hear people's, real life stories. You, like me, have been caught by the Africa bug, and so I can fully understand that.
No question. In fact, as I tell people, I think when you go through that, it becomes part of your DNA. And of course, I've been back to Africa many, many times as a researcher, and it has been an amazing experience for me.
And led much very influential research there, for which we thank you. So the sprinkle story starts, if I'm not mistaken, in the mid-1990s, when you started designing a microencapsulated form of ferrous sulfate as a means of combating anemia. I have two questions for you.
Yes.
First of all, why did you want to develop a powder in place of, for instance, a syrup? And then why go to the cost and complexity of microencapsulating? Indeed, please tell us what microencapsulating is all about.
Absolutely. Maybe I'll start back in the mid-1990s. I was asked by UNICEF to provide a consultation to them with the question of how we being UNICEF and UN agencies, can do a better job at preventing anemia, particularly iron deficiency anemia. And I went to Copenhagen where the distribution site is. We had a good couple of days together and realized that the problem was a huge problem among children, with multi-millions of children suffering from iron deficiency. Yet at the time, there was no readily available formulation to either prevent or treat it. As you know, Andrew, iron drops, primarily ferrous sulfate, has been used for many, many years, but the compliance with the use of iron drops was very poor. It has a strong metallic taste. It stains a child's teeth. And generally, you can have well-run programs, but parents don't like to have their children object when they use it on a daily basis. And of course, they don't like their children's teeth staining a brown or a green color. So when I left this meeting with UNICEF, I said, it's a big problem, but actually I don't know the answer to the problem, but I'd think about it. Came back to the lab, and I realized that in Canada, we really don't have a major problem in children with iron deficiency anemia. And the reason we don't is because we fortify baby foods that are purchased in a grocery store, and they're fortified in the factory. But fortification certainly works to solve the problem of iron deficiency. And again, I thought, why couldn't we come up with a way to fortify baby foods, not in the factory, but in the home? And that's where the idea of home fortification came up. And I thought, if we could actually teach parents to fortify the foods that they make for the children, because as you know, in most low and middle income countries, the baby foods are made from local commodities and are not purchased commercially. So I came up with the idea of fortifying foods in the home. But the way to do that had to be with something that could blend well with the foods that are being prepared at the home. And very importantly, they had to not change the taste, the consistency, or the color of the foods. And again, Andrew, as you well know, iron is a very active, biologically active substance. And if you add it to various foods, it will indeed change the color of food from, for example, white rice will turn a green or brown color. And most parents will not tolerate that. So the idea of encapsulation came up with the idea of how could we protect the food from the iron and the iron from the food. When I looked into this, I realized that the pharmaceutical industry used microencapsulation in a lot of their pharmaceutical products to mask the taste, and they call it taste masking. So if they use taste masking for various pharmaceuticals, why couldn't they use taste masking for iron? And I contacted a number of the pharmaceutical companies. There were one or two that did microencapsulation, and they said it would be very easy to microencapsulate iron. So I got a supply of microencapsulated iron. I got a supply of iron. In this case, we used ferrous fumarate, which was not quite as active as ferrous sulfate, but well absorbed. We mixed the formulations, the initial formulation actually in the hospital kitchen at night. The chef in our hospital kitchen back in those days was Marcel. And if I gave Marcel a bottle of scotch every night, he would let us into his kitchen. And in the hospital kitchen at Sick Kids, they had all these immense mixers that, in fact, they no longer used, but they allowed me to mix the iron, the microencapsulated iron, with any of the other micronutrients that we wanted to put into the formulation in the hospital kitchen, took it in a bag to a local packager, and that's how we made our initial formulation for the first studies in Ghana, actually.
This is how pioneering stuff is done, Stan.
This is how pioneering stuff is done.
So then you soon, I presume, found some funding from somewhere to support an efficacy trial. And in 2001, you published, I think, your first efficacy trial from Ghana, and lo and behold, it worked.
Absolutely. Well, the funding is an interesting question because in Canada in those days, we had something called an MRC, Medical Research Council, but they would not fund projects where there was not some preliminary data. And it is somewhat ironic when I tell you that the first funders of the work in Ghana was USAID. Irony, of course, that we no longer have our USAID, but they did actually take the chance of funding the first study. And the first study was really a comparison between the gold standard, which were the iron drops, and powdered iron as ferrous fumarate, as encapsulated iron ferrous fumarate in children who had moderate iron deficiency. And our goal was to demonstrate at this point that the powdered form of iron was as efficacious as the gold standard. So we did this randomized controlled trial, and we found to our delight that indeed it did work. It actually, the children who received iron drops were, the iron powder were just as well as the children who received the iron drops. I might tell you an interesting anecdote, again, that has to do with of doing research on new products. I packaged the product in Canada, shipped it over to Ghana. When I got there and I looked at the product, it was no longer a powder, but it was a hard gum. And I realized at that point that we had used the least expensive packaging material, which was actually paper, to package the micronutrient powders. And in fact, in the hot, humid environment of Ghana, the powder had become gum and was totally unusable. So I actually had to go back to the drawing board and find a packaging material that would protect the powder in a hot, humid environment. And again, it was a learning experience that was very useful, because from then on, we used a sophisticated 3-level package that was polyethylene, foil, and paper to package the micronutrient powders. And the reason we used this fairly sophisticated packaging was to protect the powder from becoming a hard, inedible gum.
Excellent, and that worked. So
it did work.
So were they called sprinkles in the early days when it was just iron?
Yes, in the early days, before we started calling them micronutrient powders, we did call them sprinkles. And again, the name was really descriptive because the way the product we used is we taught parents to simply open the package and sprinkle the contents of the package onto any food they were using. This was particularly important because I realized that if I were to tell parents they had to use a particular type of complementary or first food for the baby, and they'd never used that food before, the likelihood of compliance would be very low. So one of the advantages of the powdered product was, one, it didn't interfere with breastfeeding because it was used when the babies were fed their first solid foods at around 6 months of age. And secondly, parents could continue to use whatever foods they had been using for their first baby, their second baby, and the current baby. We could sprinkle the powder on whatever food was being used because and we did these studies asking parents if they noticed any change in the color, the texture or the taste of the food. And to our delight, the majority of parents said they had no problem using it. It was easy to use, and it did not change the color, texture, or taste of the food that they were feeding their children. This was very important for compliance purposes.
Absolutely essential. Now, there were then many years, decades indeed, of further work as you developed up,
Yes.
which was, took a huge amount of effort. But I'm keen to take the sprinkle story further so that we show what an impact you had on, the other multiple micronutrient formulations that are available now. So
Yes.
in somewhat short order then, it was soon after that you added some zinc, and you did studies about zinc and the effect of zinc absorption. And then based on the really well-known observation that micronutrient deficiencies rarely occur in isolation, you went further and added vitamins A, C, D, and folic acid to create what we now know as sprinkles.
Right.
Take us forward now, Stan, kind of bringing us up almost to the modern day. Can we talk about costs versus benefits next, and the cost of
Sure.
production? You've done some description to us, but to me, they're surprisingly low given the complexity of the product and also the complex synthesis pathways needed for some of the vitamins.
Right.
And you've also published an analysis of the cost effectiveness that is really important in terms of the advocacy piece to persuade national and international bodies to get behind it, MNPs. So fill us in with a bit of that, please, Stan.
Sure. Well, one of the issues that was identified, I had mentioned that when I came up with the idea, I had actually contacted UNICEF and said, I have this really interesting idea. It's simply an idea, but what if we were to produce a powdered iron with other minerals and vitamins? We were to put it into a small sachet. We were to simply illustrate to parents how it's used. What would you think of that? I said to UNICEF. And they said, well, it sounds like a great idea, but the four things you have to do are, one, you have to show that it works. Two, you have to show that parents will use it. Three, you have to find manufacturers who will manufacture it in immense quantity because, of course, there are tens of millions of children in countries around the world. And the fourth thing they said is that it had to be produced at a very low price. So, Andrew, when I started looking into the production of it, what I found to my delight was that the individual micronutrients that go into the package are indeed very inexpensive when they're used in the microgram or milligram quantities that are used in the package. Although a kilogram of zinc or iron might be rather expensive, but when you're using 10 milligrams per sachet, the cost is actually very low. So the cost of the ingredients we found was less than 1 US penny. The cost of the packaging was at least equal to, because it's the sophisticated 3-level packaging, at least equivalent to the cost of the ingredients. But the entire cost, if made in bulk in large quantities, was in the range of less than 3 American cents per sachet when it was purchased in bulk by an organization like UNICEF. So the cost of the product is actually fairly low.
It's
There
quite
is, of course, a
remarkable.
cost of distribution, which often may be more than the cost of the product itself. And it depends on the modes of distribution, whether it's being sold as a retail product, whether it's being distributed by a social entity like an international NGO, or whether it's being distributed as it is today by UN agencies where the end user does not pay for the product, but the cost of this product is either supported by one of the UN agencies, like UNICEF for the World Food Program, or indeed, as it is in many countries now, is purchased by the country in bulk through funds that come from their Ministry of Health. In terms of the economic or the cost benefit, there was one study we did with Susan Horton, who's a well-known health economist, in Pakistan. And what we showed is that the economic gains from a home fortification modeling studies, especially in Pakistan, which is a low-income country, demonstrated the cost effectiveness. It was estimated that the cost of a death averted due to the zinc's effect on diarrhea reduction was approximately 406 US dollars. And the gain in lifetime earnings due to improved cognition from the impact of iron on iron supplementation on cognition was estimated to be about $37 for every dollar spent on the program. These may sound like large amounts, but compared to other interventions, they're actually very cost effective. So the
Yeah, I was
impact
just
of
going, I was
zinc
just going
and
to say that
iron,
for people who aren't familiar with those sort of metrics, these are really low costs.
they are really low cost. So we could demonstrate that in modeling, there was a cost, an economic gain from the use of micronutrient powders. And the cost, again, per a family, if you consider that a family might have to use 60 sachets between 60 and 100, when between the time the baby is 6 months to a year of age, the cost to the family, the cost to the health system is still rather inexpensive.
Yeah. Now, it has to be said that have been other analyses that have done since then on similar products, some of which are not quite so optimistic. But I think to me, it's a no-brainer that if you can supply something at such a low cost, then it has to be a good thing. I want to throw in here, actually, one thing that one of my favorite nutrients, Stan, is riboflavin.
Hmm.
And we have huge levels of riboflavin deficiency in any population which does not consume many dairy products. And yet, I'm not aware of any study that has looked at the efficacy in terms of riboflavin deficiency of these products. I imagine that it must be really powerful. So I'm certainly behind them.
So, Andrew, we do include riboflavin in the formulation.
Yes,
And
indeed.
one of the reasons for the multi-micronutrient formulation, now it's 17 minerals and vitamins, is really advice from UNICEF, who said that if you can justify that the cost is not considerably higher with
Mhm.
multiple micronutrients rather than simply iron, zinc, folic acid, vitamin A, and vitamin D, would it not be reasonable, even if you don't have evidence to demonstrate efficacy, to include all of these formulations in the package of micronutrients? And the answer, of course, was it does make sense, even if we don't have good efficacy data, because the level we're putting in is less than the total recommended allowance. We looked at the safety aspects of every micronutrient and found that there are really no safety issues, even if the child is getting micronutrients from other sources. So we did
Mhm.
eventually, fairly early on, include all of the micronutrients in the formulation without markedly increasing the cost.
Yeah, and that's really, music to my ears. I'm absolutely agreeing with you that it just has to make sense to do it, even if in some of these we haven't yet gathered the evidence as to what impact it makes. But
Correct.
I feel intuitively that it must be powerful, especially for some micronutrients where we know there is a real deficit. So Stan, we're going to soon run out of time, but I want to end on the impact that you have had. Now, I don't want to embarrass you by asking you to blow your own trumpet, so I'm going to do it for you. But I
Mm.
imagine that you must be extraordinarily proud of the fact that this pioneering work has led to a situation where there are now so many similar products, UNICEF's MNPs, which you've just alluded to, which contain 17 vitamins and minerals. And I came across China's Yin Yang Bao, which has been widely distributed to millions of young children in China's most deprived regions. So maybe we could end with a bit of a summary of what is the latest situation, Stan, and then, what are your thoughts about the future?
Well, thank you, Andrew, and I appreciate it. I do want to make the point that, of course, you're interviewing me as a representative of the micronutrient program, but the work was done by graduate students, by colleagues, by other researchers around the world. Though you're giving me credit for this. It was really something that was done by many people around the world, and I, of course,
That's true,
could
but
not
they
have done
need
it
a,
alone.
that's true, but Stan, I'm going to stop you because they always need a leader with a vision, and that is what you provided.
Well, thank you very much. Well, to tell you where we are today, UNICEF is the major procurer of multi-micronutrients for children between the age of sort of 6 months and 2 years of age. Um, in terms of supply and procurement in 2025, they're planning on producing 15 to 25 million boxes of micronutrients annually, which is suitable to treat anywhere between 10 and 25 million children in in countries that need it, including Asia, Africa, and Latin America. The distribution is primarily from Copenhagen. There were three things that happened that really aided the distribution. One was that the World Health Organization came up with recommendations as early as 2011, have updated the recommendations in 2018 and 2023, recommending the use of home fortification with micronutrient powders where the incidence or the prevalence of anemia in a country is greater than 20%. That was really important for getting countries to take this on. The second important fact was that micronutrient powders were included in the model list of essential nutrients, essential drugs for children, that is WHO, their model list of essential drugs for children in 2018 or 19. And finally, the fact that UNICEF and the World Food Program have agreed to worldwide distribution was particularly important, because what I didn't talk about is that it's relatively easy to do the research, but actually to do the implementation, to do the distribution was not something that I could do at all, and certainly not at all alone. So finding the right partners, and certainly the UN agencies were the right partners, has turned out to be a good decision, given the fact that they do the procurement and to some degree pay for it. But because the micronutrient powders are listed in the essential list of drugs, countries can justify using their health budgets to pay and procure for the product. That was really an important implementation point in the recent past.
Absolutely, and I see the impact, day to day in my home country of the Gambia, where that has made a real difference. Stan, maybe a last question then is, what are your thoughts about, I know there have been some studies looking at social marketing to see if we can actually get mums and families to buy the products themselves, because as I go into my little shop in Canabar, I see all sorts of commercial products available, many of them with a very poor, even damaging health profile, but I don't see sprinkles or any analogous product for sale. What are your thoughts around that?
Well, Andrew, there were a number of social marketing programs that started, particularly in South Asia, in Bangladesh and Pakistan, which were relatively unsuccessful for reasons that aren't particularly clear. And I think it has to do with the fact that one uses the micronutrient powders when one has a child between 6 months of age and 2 years of age. And after that, it's probably less appropriate, because with a wider variety of foods available, most children can meet their micronutrient and nutrient needs. So I think what they found in the social marketing programs was that the audience was hard to identify. And it changed all the time, because a parent might have one child or two children or three children, but once the children have reached 2 or 3 years of age, they no longer need the product. So I would say that the reason that the social marketing campaigns and certainly retail campaigns were not successful is because of the nature of the product and the nature of who would buy the product over time. So I think for those reasons, the major distribution now is through the UN and through the public sector.
Yeah, my personal view is that we will get there in that respect. I mean, when you look at how we overcame micronutrient deficiencies in Europe and North America, we didn't do it by NGOs and United Nations coming in and doing it. We did it basically through the food chain and through medicines and through education of parents as to what were the principles of good nutrition, how their children would grow and thrive better. So I'm fairly optimistic that actually we will get there, particularly as you've got such a wonderful product with such a comprehensive evidence base as to its efficacy.
Well, I would hope what you're saying is absolutely true. And I think that you would agree that for a product like this, there has to be sort of multiple distribution modes, so that for some families who want to buy it, they can buy it, and other families that don't. We had a program in South America. And as I introduced the program in one of the countries, who was actually in Guyana, the Minister of Health was there when the program started. And he came to me and said, I don't avail myself and my family of these social programs, but I want to use the product. How can I use the product when I can afford it? And that's a great example where you do need multiple modes of distribution, sales, whatever you want to call it, in order to really get the product to all of those children who might need it.
And that's a great optimistic point for us to end on. Professor Stan Zlotkin, it's been a huge pleasure to hear the stories of sprinkles and how that first idea led the way for so many related products. And I guess, it's not really my prerogative to do this, but I'm going to do it anyway, which is to thank you on behalf of some of the poorest mothers and children worldwide for your many years of commitment towards eliminating malnutrition. We can see that you're still very vibrant and hard at work. Your work is not done yet, and we wish you continued energy and success in the future.
Andrew, thank you very much. It's been a great pleasure and lovely seeing you again.
And thank you all for listening to this edition of our podcast, Milestones in Pediatric Nutrition, part of the NNI Bites Big Learning series. If you have enjoyed learning about MNPs, please be sure to subscribe through either the NNI website or the NNI 365 app so that you can hear more conversations with pioneers in pediatric nutrition.
Thank you for joining us on Milestones. For expert-led discussions, scientific publications, and educational resources, visit the Nestlé Nutrition Institute website. Follow us on our social channels and subscribe to never miss an episode. Join us again tomorrow as we take nutrition science further, one milestone at a time. Wishing you a season of learning and discovery.